Randy, it's interesting that we have worked tangentially, right? For like 4 years now, but I feel like I've gotten to know you maybe in the last year and a half. And I would say the very first thing that I remember is the 2020, maybe three I2 symposium, where we spent the majority of the conversation talking about your racing and cars and all of these things that are like this very interesting conversation about you. So I'll let you give your intro because I feel like you have so many interests that are all incredibly interesting, and I will do a poor job of knowing the ones that are incredibly important to you to get out there.
I appreciate that. So professionally, I know that the conversation often steers itself to racing and to cars when you're around me. So I apologize in advance about that. But professionally, I am trained as an epidemiologist. And so the tools that I use and my skill sets have become very important, not only because of the pandemic, but because of the focus on really digital transformation in technology and processes and people. A lot of the things that I like to focus on is how we make the work that we do translatable to the real world and really impact health outcomes. I'm currently a professor at Washington University in St. Louis in the School of Medicine, and my colleagues and I represent the Institute for Informatics, Data Science, and Biostatistics, which is really all things data and trying to harness all of the electronic health record and other data that impact our health in the region and beyond. And so that's what I spend most of my time doing. And then on the side, I like to race cars and top cars.
Which is awesome. And I certainly enjoyed that conversation. I take this work really seriously now, right? So not that I've not taken work seriously, right, forever, but as we got to partner with Washington University, this was back when it was the Institute for Informatics, not quite, biostatistics and data science now. I don't think as an outsider, right, I ever had this understanding of how much data is impacting our ability to provide quality care in this country. The first year you're just underwater, right? We were exclusively technology, and we're just trying to keep up with the terminology that the entire team was using, and how did we have a really nice focus on what we could enable. And now I talk with so much pride, right, about being able to support institutions like WashU and your Institute for Informatics, Data Science, and Biostatistics. We're a small part of it, of enabling, right, the work you do, but it feels really big to us. So I'll say thank you, I think, for giving Chris, myself, technology partners, the whole team, an opportunity to work on these things, because I think it's been very enlightening on the work that we want to spend the rest of our professional careers working on. And so with that, let me jump in. The last time that we chatted prior to this, what struck me was how thoughtful you were about the effective collaboration between data scientists and researchers, right? The data people doing translational science and the people providing care. Can you talk to me a little bit about what you've seen change again, and kind of maybe rewind for the people that are going to watch and read? Your thoughts on that?
Absolutely. And I do want to thank you and Chris and your colleagues at EdTech Partners for being mission driven with us. I think that really having the patients and their families in mind as we do this work is critical. And I think that you all have been patient with people like me as well, in terms of waiting for me to learn the technology and waiting for me to learn the terminology, quite frankly. And so now I think that we have a much better understanding of each other and what we do. And, it really also bodes well for the communication that we have within our research teams. So to your point about my passion for doing the right thing with data, I also want to do what's clinically relevant with data. And so the communication between researchers like me and clinicians who are providing the healthcare at the point of care and beyond to patients and their families is a really critical relationship and a really critical foundation for communication in order to create something that's clinically impactful. And quite frankly, ultimately, something that I want to see is that it's impactful from a public health standpoint. And I can give you an example of a success story. You're familiar with this because you've helped us with this, but maybe the audience isn't familiar with this yet. I've been collaborating with physicians from our palliative care group, as well as internal medicine and hospitalists, to create a better prediction system for mortality among patients who are hospitalized. And this is really important to get right, to know who is at risk for mortality, but also to provide our clinical partners enough lead time to have critical conversations with patients and their families leading up to potential end of life and really documenting goals of care. And so through the creation of this algorithm, it's been all about data. And like you said, we have this tsunami of data that we've had to harness even in the first 24 hours of hospitalization, which is what our algorithm is based on. There's so much data from laboratory values to vital signs to demographics, medications, and we brought all of those key features together to predict 30-day mortality really accurately. And the exciting part about that is now we can notify the attending physician and healthcare team that this patient may warrant a conversation about the end of life and documentation of goals of care so that they are approaching their end of life and getting the care that they want to have so that it's not an isolating experience for them or something that they weren't counting on happening. And quite frankly, the resources in the hospital can be better directed towards more acutely needy patients if we get these patients towards the end of life in more comfortable settings and also, quite frankly, in less expensive settings in terms of care delivery. That benefits the patients and their families as well. But isn't it a gift to be able to have these conversations when patients can weigh in and have a say in how they want the rest of their life to be carried out and not be worried about what's going to happen to their family, as they're being wheeled away into the ICU, for example. So I think it's all about data, and a lot of it is, technology, at least from my perspective. It's machine learning and artificial intelligence, but it impacts real lives and it impacts them in a really powerful way. So I'm happy to be part of it, and I know that you all are too.
That is such a great example, and it's I think it speaks to the journey too that Chris and I have been on. And maybe I shouldn't speak for Chris Lundeberg, right, my peer in this thing, but I do, whether he likes it or not. Sometimes I'm sure he does the same. But it's about our professional maturation too. I feel like at times this is uncomfortable, for me to talk about, right, at times. And I like, oh my gosh, mortality and how people are going to die. Like that's their world. Let's talk about platform as a service, cluster-based architecture. How do we deploy layered data, right, in API? And now I find that I want to know more. I want to understand, because what you just painted is how data kind of enables each point of this patient care triangle, right? The patient and family. I lost two grandparents, right? As we all do. They're both aging. My grandfather died right before his 90th birthday. He was living with my wife and our three kids. We have five now, but three then, for the last 4 years of his life. And it was such a different experience being able to know what was coming, talking to him about, the plan with his physicians, versus my grandma, right, who we just didn't have that planning in place for, 4 years prior, almost 5 years prior. That was hard. It was on all of us. The end was very challenging over the course of the last, 30 days or so. And with him, it was, okay, what do we got to do to get him down to Central Missouri to go see his 94-year-old brother? We got to make sure we can do that. We got to make sure we have a good lunch there, right? how much can we spoil, right, the last, 3 weeks or so to make sure that he's comfortable and enjoying the heck out of himself? It's a very different experience, and we were lucky to have that. But I think we were lucky to have access, great medical care. I think we represent individuals that largely probably, are well represented in your data, so that patient experience moves forward. And then you got the hospital operations and team, right? How do you only have so many ICU beds. You can't be everybody's everywhere, everything anymore, right? You got 1% to 2% margins. You need to be thoughtful about how you run those pieces. And then there's this translational science piece of you got a meaningful use case and you have data that says, hey, we could make both of these other things work a lot better. And so I want to be in the middle of that stuff now versus pulling, back and saying, oh, this is a bad subject. I don't want to talk about mortality.
Absolutely. And technology can be the enabler here. So I think a lot of people, when they think about artificial intelligence, just tossing that term around in a lay audience makes people really nervous, especially in the context of healthcare, because wait a minute, are human beings delivering my care or is the computer delivering my care? And, in this case, we give the end user, the clinician, the ultimate decision about whether they're going to have the conversation with the patient or the palliative care team is, or maybe they've already had the conversation and they just haven't documented it. And this is a good reminder to have it documented in case they're not there at the critical time for the patient. And they can also tell us, we don't think that this is an appropriate time to have this conversation with the patient. In other words, maybe the algorithm got it wrong. And so we really want to have the technology in the mix to deliver and really collate all of this information so that the clinician can make the right decision and really close the loop in healthcare delivery. Because otherwise, it's up to the clinician to make all of these decisions based on all of the data that's available to them. And quite frankly, they're very smart. They can process a lot over the course of a day, but they can't process as much as a computer can in that short amount of time.
You, Dr. Philip Payne, Dr. Lai, Dr. Moore now, right, and Dr. White, I think all at WashU have been very thoughtful the entire time I've been able to have a conversation with any of you individually or together about AI as a co-pilot. I'm always impressed by how you want physicians to be able to operate at the top of their license. Give them what they need to know, when they need to know it, to be able to be the best provider that they can be. And that works all the way across, right? From kind of nursing all the way through, physicians or ER and the ICU and other spaces. How do you guys come to unify that? Help me understand a little bit about how you view AI as a co-pilot in this setting. Like you just said, right? We want it to do, and maybe I don't want to lead you too much here, but my perspective from talking with you is you all want to help it make the prediction, but enable the best judgment and not make that judgment in healthcare. Is that right? Am I missing it? Like, what are your other thoughts?
Yes, I think that's exactly right. And something that's top of mind, because I was just speaking to someone about this morning, is just because we can do it doesn't mean we should do it. So part of this is intentionally making sure that this isn't as crowded of a space as it could be. We can use these data and predict anything. And we can probably be pretty good at predicting things utilizing medical data. I think I used the example this morning that I could probably predict toe fungus, but that might not be the most important thing to be predicting among patients. And so making sure that it's clinically relevant and it's actionable and it's meaningful. And the reason why I think that we should pause and really assess whether these things are going to be useful in clinical practice is to make sure that we don't crowd the space. So we could be letting the clinician know every second of every day that the patient is at risk for this thing, or is due for this test or that test. And that's a lot of extra information that may actually detract from care. So it's going to be really important, much like I've done with Doctors White and Moore for this palliative care project, is making sure that we're delivering the right data to the right people at the right time and not overwhelming them with information, but giving them the information that they need to enable that decision. We're not bombarding them with extra information that isn't relevant at that time. And that's going to be critical moving forward because we can predict a lot of things, but taking the time to ask, should we? And if so, when should we? Like, what's the best timing for this? When are decisions going to be made in this realm? Because we want to get all of that. We want to get the timing right. We want to get the people right, and to really impact health outcomes.
One of the challenges I've seen with that right now personally is it's for these pieces to work. Like you just mentioned, they got to be a part of you got to get the right relevant information, the right accurate insights at the point where it matters, which means it's got to be in the EMR. That's not easy. That's really, really challenging to containerize a solution and make sure that you follow all of, I'll use Epic in this instance, right? Get all of their boxes checked across, an implementation team is not easy. How do you keep moving? Because that's frustrating. Like I've been frustrated about the work that we've done and the time it should take just to get through EMR pieces. How do you keep going?
I like to say, and I'm sure I've been quoted as saying that the technology is the easy part. And sometimes I've said that casually when I've been presenting at a conference, and then the next speaker comes up to the podium and says, I'm here to talk about the easy part. And then I feel really guilty that I've just dispirited their work. But really, it's not as easy as flipping a switch, right? Like we can't just turn this stuff on at the moment that we need to have it turned on. So the hard part, the challenging part is the people and the processes. So I have a grant right now where we're scaling what's called a clinical decision support tool, which is a web application that's embedded in the electronic health record. So it doesn't operate outside of the electronic health record, it's a part of it. And it automatically populates with data and visualizes those data at the point of care. And getting this tool into different EHRs, different electronic health records across the country has been the biggest challenge. And it's not because we can't do it. We've done it a dozen times. It's that we haven't necessarily done it with those partners at that institution. And there are a lot of hurdles that have to be crossed in order to have this tool be acceptable to security teams and data governance teams and clinical teams. We need clinical champions in place, but we also need information technology champions at those institutions. And one of our biggest struggles was competing demands. And this was during the pandemic, it was very evident because information technology teams were being pulled in many different directions. A lot of them were being used to broker data for different stakeholders and to get the minute by minute COVID estimates out of the electronic health record. So a lot of these folks were being repurposed to be data people, even if they were process people to begin with, they were being repurposed. So during COVID, you had all of these competing demands, and we were still trying to get our clinical trial off of the ground. So we were still trying to get the clinical decision support tool embedded in the electronic health record. So I think there's always, in health systems, there's always competing demands for this very limited bandwidth of information technology and resources. And we need to consider that as we're moving these projects forward and really be able to move certain aspects of the process along while we're waiting for approval by one committee be working with another committee to push it forward. That's what I've found.
I think that's fair. For us, we're not in the system level challenges sometimes, right? So those additional technical challenges at that bottom layer that come with healthcare, we're like, why? Like, this is not that challenge. This is 2 weeks worth of work. It can't be 6 weeks worth of, approvals, or sometimes 12 weeks, like, right, we've experienced. If we could, though, maybe hop to some of the system level challenges.
Sure.
I really enjoyed the conversation that we had prior to this, which was really diving into the system level challenge, right, which is significant on population health and data collection and who's represented, not only by where you get care, right, but kind of who you are and your access, and maybe it's how there's some system level biases, right, built in. As we push super hard, right, on machine learning and deep learning and, now general pre-trained transformers, right, of which you guys are a nice heavy user now. We're building models, right, that you kind of help me understand this. We're building models for the people that are already getting the best care sometimes, because those in the rear view mirror of care currently have been there and they're not represented. Talk to me a little about that. That you got pretty passionate about that, which stirred some conversation for me to get passionate about. And like, okay, we've got to think about some things. How do we help? If you could walk, our clinicians, a lot of the professors, providers and health system leaders certainly get this conversation, but I think your passionate perspective on it is good for even them to hear.
Absolutely. So I recognize that the data in the electronic health record is no doubt very predictive for patient outcomes. It's really missing critical elements, though, regarding where the patient lives, works, and plays. And really, when you think about what impacts health, what really impacts health, no offense to the clinicians that are listening, but it isn't necessarily the doctor that we have today that impacts our health. It's our upbringing. It's where we grew up. It's the resources that we've had throughout our lifetime. It's the health insurance that we have. And so when I think about representativeness of data collected within a given health system, that's representative of the patients that can access that particular health system. It doesn't necessarily scale to the patients that are waiting in the wings or that are underinsured from a health insurance perspective. It speaks to and about the patients that are already being seen. And I think a challenge for somebody like me, recognizing that the social determinants of health, right, the type of health insurance we have access to by virtue of the type of job we have, the access to transportation that we have that allows us to get to our doctor's visits or not, or our preventative care visits or not. Those are the true upstream, if you will, determinants of health. And those are the factors and features that aren't necessarily represented in our most proximal electronic health record data set. It says that you have a missed appointment. It doesn't say, oh, the bus was running late that day, or it couldn't run on a day like today because of the ice storm, and so you weren't able to get to your appointment. So it doesn't speak to those really core features of what enables our ability to be healthy or not. And we miss out on a pretty large piece of our patient population or our prospective patient population if we just focus on the here and now. So I can give the example of a mom. Maybe she's covered by Medicaid and she shows up today to our health system to give birth, and we've never seen her before. So we have data on her birth today, but we don't have any history of her because either she didn't seek prenatal care or she didn't come to our health system for prenatal care. So we just have a snapshot in time on this young woman, on this young mom, And we don't know any of the predisposing factors that got her here. We don't know why her pregnancy might be high risk or not. We don't know that she might have a history of preeclampsia because we don't have those records in our system. So that's a very simple example of somebody seeking care through, for example, the emergency department, and us not having a long history on them in preventive medicine or prenatal care to be able to, quite frankly, give them the best care. We have to find out a lot about that patient during a short amount of time in order to deliver high quality care to them. So, a way that we're trying to address this particular problem actually is to partner with other health systems, other healthcare delivery systems in the region to get a more comprehensive picture of these patients that might show up in our health system for childbirth. We want to be able to know that more comprehensive history. And I think that that's a metaphor for patients who may come in and out of our health system because of being eligible or ineligible for certain tiers, if you will, of health insurance. We might see a patient for a particular diagnosis and they could get that particular diagnosis covered by their health insurance, but then they may lose their job and lose their health insurance, and we might not see them again for a couple of years span. So the gaps in data and the gaps in health are really explainable by social determinants and less so by the quality of care that we're able to impart in any given place or time.
Yeah, it's interesting, right? I mean, care is like one part of our life, right? It's one facet, right, of the whole picture. You know, a similarly interesting person, Dr. Jeff Thompson at KUMC, right? He's their CRIO. And we had a really good conversation on rural healthcare, right? And thinking about that as a group that has not largely, since about 2015 or so, they've disengaged more with healthcare as urban populations continue to engage more. And I just kind of asked him, like, what are we going to do about it? We all win when babies are born healthier, to your, mother example. We all win when babies are born healthier. We all win when that baby and mom stay healthier, right? Mom has a job, is working, I mean, from a taxpayer base all the way to, future dependents, we all win as a society, right? And all the good things that come with being healthy as well. But it doesn't feel like it should be this hard. And kind of a part of the natural conversation we had was there's competitiveness between hospital systems, right? Margins have never been more narrow. Everyone understands the value, but this is a system thing. This is a regional challenge to solve, not a KU or the WashU School of Medicine problem to solve. It's going to take a lot of hard work. What other steps do you see in the next, I don't know, 3 to 5 years of being something that pulls care forward together more equitably?
I think that one challenge with our current healthcare system is treating acute problems as they arise and not having as much incentive around keeping people healthy throughout the lifespan. It's almost like we're getting really good at these very drastic measures and saving lives when we should be, in my opinion, focused more on preventative medicine to keep these very drastic, very heroic measures from being needed in the first place, or at least kept to a minimum, or at least prolonging healthy lifespans. And for that to happen, more of a focus on preventive medicine, primary care, incentivizing wellness visits, incentivizing people to stay healthy and stay engaged with the health system, not in a sick way, but in a healthy way. And that again is driven by upstream factors. So when you think about health policy, that's what really plays a role here is what are we rewarding in terms of healthcare delivery and medicine? In current systems, we're rewarding keeping people alive in these heroic measures. We aren't necessarily rewarding keeping people healthy. And I'm a public health person, and I know very well that it's hard to put a return on investment on something that doesn't happen, right? So when we can keep the bad thing from happening, that doesn't translate to ROI as easily as if we can replace that need and make sure that that person is able to contribute to society again and go back to work again, for example. And so that is always going to be the rub with prevention is making sure that we keep an emphasis on keeping people healthy, even though there isn't a really clear, really instantaneous return on investment. The payoff is going to be in the longer term.
So this comes up a lot, right? Fee for service, value-based care. How does it play a part in these already kind of slim operating margins within hospital systems? Is it going to take something like kind of the campaigns to stop smoking, right? Maybe this kind of came up in my head, so I don't have, definitive statistics on it, right? But there's a very different charge, it felt like, on getting people to stop smoking and recognizing those dangers and even the questions, right, that would likely be asked by primary care physicians, right, changed over the last 20 years. Is it going to take like a full court press like that to be like, and I don't know what you call that, like, take care of your body, please, before you're 50? I don't know. But is it going to take something like that, plus value-based care incentives to move society forward over a couple decades? Or is this thing so complicated from a private insurance, health system, some level of government intervention that it's spinning away from us faster than we can rein it in?
Mm-hmm. And thank you for using the smoking example because I used to work for the Nicotine Dependence Center at Mayo Clinic. And
I
so,
didn't know that.
yes, that was a blip on my radar that I must not have told you about. Actually, I was there for about 4 years.
That's not a blip. That's 4 full years. I got a 6-year-old at home.
As I get older, it becomes blippier.
Okay, I'll take it.
But at any rate, I can actually tie into a lot that I think we need to do healthcare system and health policy wise that happened over the course of smoking and anti-smoking campaigns. Because it wasn't just the campaigns, it wasn't just the health labels on the pack of cigarettes, it wasn't just the quit lines that different states established to help people call and get nicotine replacement therapies and get counseling around helping individuals quit. It was really a cultural shift. And it was a cultural shift because we had policies around clean indoor air. So a lot of people don't remember that it really wasn't anti-smoking policies for bars and restaurants. It was clean indoor air policies. So it was the right for everyone to be able to eat in an environment where you had unpolluted air, unpolluted with tobacco and its constituents, right? And so all of that collectively led to the shift that we see, and only now vaping is bringing the rates back up again. But about 15 to 20% of adults in the United States are current smokers, which is a drastic change from the 1950s, for example, when all of this started, all of these different targeted efforts to help curb smoking started. It's not just a health system by health system change that has to happen. There really does have to be policies around preventative care and incentives around preventative care to make this type of shift more accessible to everyone. Because until that happens, it really is the haves versus the have-nots that are going to be able to make this change and going to be able to see a difference on their bottom line when they're delivering more preventative care services. And so examples from those health systems that are integrated health systems are going to be really important to demonstrate the evidence, but also having these incentives in place so that health systems without as many resources can also make the change. And once those policies have changed and once health insurance works differently, then the individuals are going to be empowered to start making those changes. And it's really going to be a cultural shift in the society towards being healthier. Right now, it's so hard to be healthy because it's up to you to get a gym membership and it's up to you to get to the gym every day.
Yeah.
Nobody
Don't remind me. I did not go to
Right.
with this weather. I was out. I slept in and did not go.
But it shouldn't just be up to you to make yourself healthier. We need to make the culture and the system amenable to making everybody healthy.
It's hard, right? I mean, you look at obesity rates, right, across lines of, economic prosperity. It's there in this country more than others, right? So we've got a more challenging piece to run at. It feels to me in some of these conversations that value-based care, paid great, it's certainly a way to help push us all forward from like a system perspective within providers, but nobody has the data to prove out, hey, here's why you need to let me do this thing now before an emergency. You should pay for this thing for me to do this intervention or treatment now versus a hip replacement in 6 months.
Mm-hmm.
That seems like a challenge. Does it start there? What is it? How do we make some big push forward to help people take better care of themselves before it's too late?
Yes. So I think, this goes back to the return on investment of prevention. A lot of the changes that we can make now among, like, let's say children born at the hospital, right? To go back to my delivery example.
Everyone loves babies.
Yeah, if we change right now how we are treating those children, we won't see a benefit for 40 or 50 years, at least, right? From a population perspective, we're not going to see any big shifts in how healthy that generation is until they reach my age, right? Middle age. And then we can compare their status to that of my generation or previous generations. But if we wait another 40 or 50 years, it's too late. So I think a challenge that we have in proving this out is the healthcare delivery system isn't static. Medicine isn't static. And what I mean by that is we're constantly evolving in terms of how we care for patients and innovations that affect outcomes of patients. So what we might think is attributable, let's say a improvement in health that we see among heart failure patients, it might not be attributable to a push in society for eating lower sodium. It might be attributable to beta blockers and the uptake of beta blockers in that population. So treatments continue to change and evolve, which makes it difficult to look back 50 years, for example, to follow that patient forward and see what happens because nothing else is standing still. So we'd be hard pressed to find something in medicine that we could really look back on and say, if we changed that one thing, what would the counterfactual look like? What would the opposite thing that we want to see happen? What would health look like if we changed that one thing? That's going to be really difficult to do. So I think that even with good historical data, that's really difficult to do because all of the secular changes, not only in our environment, but also in our health systems over time.
I don't think I had thought about that, right? I mean, the dynamism and the causal pieces for health outcomes are almost, it's hard to make decisions in the future, right? If you can't be certain about what the pivot point was or the factual reliance on, hey, this thing worked. Well, a group of them likely worked. We're data people, right? Cloud infrastructure, security people, data engineers, data scientists. From your perspective, how do you envision the role of technology advancing population health in the next decade? What things are you really excited about?
I'm really excited about the speed at which we can do the work that previously would take a lot of computational power and a lot of time to get an answer to a question. So I'm really excited about being empowered with new infrastructure to be able to come up with answers to questions faster. I'm a bit discouraged that we will have all of the data available at our disposal to be able to make the right decisions in all contexts about patients because we're missing in the electronic health record, for example, some critical pieces of the story for those patients and those families. I think one path forward that I'm encouraged by is data sharing and the data sharing that occurred during the pandemic. I can speak to what happened in our region and how, even though the four health systems in our region are normally competitors, they realized they were in this pandemic together and they needed a more comprehensive picture of patients and their trajectories and what the risk factors were for having poor outcomes when a patient was diagnosed with COVID. And so the health systems in our region stepped up to the plate and shared key data elements with actually our team at the Institute in order to reason on those data and inform the broader region through the pandemic task force. And I'm encouraged by data sharing efforts like that because we really were able to gain helpful insights that educated not only the healthcare providers themselves, but also the population about social distancing and hospital capacity and all of the other factors that were greatly impacting their lives in that window of time. I guess the pandemic was probably as much of a blip on my radar as my, my stint at the nicotine dependence center. But I am encouraged about the capacity for data sharing and the literal capacity for data storage and our ability to reason on large amounts of data in a short amount of time.
Do you think, and this is like, I'll ask maybe a couple rapid fires here. Do you think there's enough bold leaders out there in healthcare to actually do this work long term? Honestly, because I know the ones that I know are going to be like you. They're gonna figure it out. They're gonna say, hey, we may not have expertise in like a cloud data platform, but we know it's very easy to share, Delta files. And in your guys' case, right, Databricks made data sharing and has continued to make data sharing nationally much easier. But you have to take a bold vision to make a big jump. Do you think there's enough there in every system to get that work done together?
I think to a certain extent, it's up to those bold leaders to bring others along. So, an example that I can give is implementing the tool, the clinical decision support tool that I was talking about, implementing it across cancer survivorship clinics across the US. We have demonstrated that it can be done. We can help them achieve it in their own health system. And these are not academic health centers. These are community oncology practices. They don't necessarily have, and I'm not speaking disparagingly about them, but they don't necessarily have the resources at their disposal that an academic health system would. But bringing them along and seeing the success of them being able to implement this tool at scale in their clinic is what needs to be done. And it takes bold leaders to be able to disseminate the information, demystify the process for others, but bring them along and really show them the way for data sharing and a lot of these advances in technology, because not a lot of leaders, in my experience, will be self-motivating and will have the incentives and see the benefit of going down this road, because it becomes easier as you go, but it's very difficult in the beginning. And you alluded to a little bit of that, like what we had to work out together and learn each other's terminology and really share in goal setting and where we're going together. And that's the hard part. But once we get a rhythm and once we get that momentum, it's much easier to keep up and it's much easier to bring people along. So I'm hoping that the leaders in the field do just that.
You bring up such a good point. The first year was so much of environmental scanning and understanding and kind of prioritizing, right, the core functionality of what it meant to have an incredibly capable healthcare cloud data environment. And now, I mean, kind of by sprint, I'm like, I cannot believe how much we're getting done, right? I mean, it's crazy to think about how far an institution like this Washington University School of Medicine can come in a short time. But I do attribute a significant amount to that, to the boldness of the leadership. Obviously you included. There's huge goals, a significant amount of care, and as you mentioned, a lot of resources, right, which are important to be able to utilize and move forward. Maybe another question I'll hit you with: are you worried about anything kind of being localized, right, for health benefits moving forward? You touched a little bit about this. You just hit on this with the oncology, clinical centers, but academic medical centers, especially R1 institutions, right? You have an army of researchers and not unlimited, but a significant amount of resources to impact the populations of which you see, right? And your kind of sister hospital systems, or sometimes same hospital systems, right, are able to care for. Are you worried that there's going to be significant geographical health disparities outside of some of the other social determinants of health, like, economic status and race and other items?
When I think about this, I think a lot about what goes on locally and really how much changes locally that we have to keep up with. And so what I worry about is not only keeping up with the outside world and being able to generalize our findings to other settings, but also keeping up with what's going on in our walls. And what I mean by that, I think it's exemplified by the mortality model that I talked to you about earlier. We built that first model in 2019. And then we scaled it to the hospitals within our healthcare system during the pandemic. And being an epidemiologist, I got really worried that the model that we built in 2019 may not perform as well when people started dying of COVID, which we hadn't heard of in 2019.
Right.
And even during the pandemic, our patient mix changed. So we had higher risk patients very early on. The risk was high in dying of COVID. As the pandemic progressed, thankfully, the virus mutated and got a little less fatal, a little less severe. And so we retrained our model internally quarterly. And we won't need to do that under normal circumstances that often. However, I think it's important to make sure that our model and anything that we put in the electronic health record maintains its internal validity to our institution, and that impacts how generalizable it can ultimately be as well. If it doesn't work in our system as well, it probably isn't as scalable anymore either. And so thinking about what we can do internally to bolster that confidence in whatever intervention we deploy can help us better do outreach and scaling to other health systems and other populations.
And you think about much of the work typically, machine learning and other model creation will typically fall apart. It's very challenging to generalize because of the population differences within one setting to another. let alone thinking about the commonality of EMR terms or care terms, right? That kind of can influence those properties. I think there's a really easy approach in which you guys are trying to make, well, I shouldn't say easy. That certainly is not the case. Let me reword that one.
I've got
There's a smarter approach in which you're trying to take, which is you can certainly think through the trainability of a product that you build and how does it generalize by learning, right, across the individuals that you serve. And that's a huge part of it that really gets lost. I think some people would much prefer we bought it off the shelf, we've plugged it in, and now it's good. But you lose your explainability, right? And you'll gradually lose that performance as well. So I think you all have taken the right approach to what machine learning will likely continue to look like in healthcare, right? Which is a great foundation that has to be thoughtfully implemented and learned within a specific environment. So at the end of time, any closing thoughts you want to add here? It's been wonderful, by the way. You continue to be, I almost want to say friend. You're getting pretty cool. I feel like we're getting close.
Thank you. I appreciate that. Yeah.
Thank you.
Well, I'm really grateful for this opportunity too. It's not very often that I get to spout about things epidemiologic and have people pay attention or at least pretend to. But at any rate, I've really enjoyed the conversation. One thing that I would like to end with is we should be, in addition to being thoughtful about the types of interventions we deploy and the types of data that we use and how generalizable our results are, we need to be training the next generation of data scientists, biostatisticians, informaticians, epidemiologists to address the same concerns moving forward as the technology gets easier, as the tools get more accessible. I want us to continue to be thoughtful about the work that we're doing and to ensure that the interventions that we're putting into place at the point of care and beyond are enhancing the health of everyone and not widening disparities. Because I think this goes back to the who gets in through the door and when discussion that we had around who our patient population is and who they aren't, is really important to consider here. And so continuing to be thoughtful about that and training thoughtful future leaders in this data space.
That's awesome. And I appreciate that. I think we talk a lot about the right cloud platform approach enables team science at scale, right? Internally and externally. I think, we kind of talk a little bit about this, but the era of hero science is over. You can't do what you need to do on your SQL server under your desk. You have got to work together, right? In an environment that enables, right, the totality of outcomes, right, to be recognized. The hard part about that is if there's no one to do that hard science work, it won't matter, right? And I think being thoughtful about making sure that the best and brightest on the data science side happen to make their way into informatics and not Wall Street is probably good for all of us.